Good afternoon, buenas tardes. Welcome to those of you live here. Thank you for joining us. And thank you very much for all these people who are joining us online. I'm Spanish, but I'll be speaking English. We'll be dealing with both languages today. We have simultaneous translation online, and I believe here in the room as well. So we'll try to balance with both languages. We're very lucky that I think we had 1,500 people that were registered online. They will not show up, but some percentage of those will be here. And anyway, we'll keep in touch with them to the materials we're presenting today. So my name is Joseph Figueras. I'm the director of the European Observatory on Health Systems and Policies. And I'm really, really happy to welcome you here on behalf of the Ministry of Health, who's steering us today, who's welcoming us today. On behalf of the European Commission, we'll be speaking, and indeed on behalf of the World Health Organization Regional Office for Europe. What do we want to do today? We want to do two things. First, we want to present two major documents. Unfortunately, I'm not sure we have paper copies. They got missing somewhere in action, but we are paper conscious as well, so this will be distributed electronically. One is the health system review that the European Observatory is doing with our colleagues in Spain. We'll be presenting that in a minute. And the second one, which is already there for a while, is the country health profile by the European Commission, done by the Observatory with the Commission and with the OECD. Both documents will be sent to you, will be available. But the second and most important thing is, of course, to talk about and present the Spanish health system, and as importantly, in an European context. What can we learn from Spain? What Spain can learn from other countries? My agenda, if I have an agenda today, if we have an agenda, is to demonstrate once again that comparing systems is policy relevant, is useful. You can learn from best practices, you can benchmark, you can contrast experiences. Of course, the contexts are different, but still there's a lot of learning to be done. So, first of all, we will have a video address by Sandra Gallina, Director General of Santé at the European Commission, followed by the welcome of WHO and Spain, the Ministry of Health. So we'll have first the video of Sandra Gallina, please.
Minister, ladies and gentlemen, queridos amigos, thank you for the opportunity to address you today. Our health systems face major challenges, as we all know. If we want to address these challenges, we have first to understand the problems. And this is why it is essential to assess health systems properly. The state of health in the EU is our joint project with the OECD and the Observatory on Health Systems and Policies, and I thank them both. It provides evidence-based data in order to shed light on both health system challenges and successful policies. Now, thanks to the excellent work of our partners, the Observatory and the OECD, I repeat, it has become a point of reference for academia, national authorities and others. Now, that said, making international comparisons of health systems is not straightforward at all. Challenges come not only from problems with performance of health systems, but also because, they may reflect other social determinants of health, like poverty of housing, how the health systems generate and deploy resources. Now, the state of health in the EU gives us some interesting insights into the performance of health systems. Now, this hopefully helps raise awareness and invites policy debate around improving health systems outcomes. It is also why the state of health in the EU features prominently in our policy processes, such as the European semester. Now, Spain can be proud of achieving relatively good health outcomes with lower health spending compared with the rest of the EU average. The health systems provide good, I would say, coverage, and I would say it's a really good system. Spain has also, I would say, very low rates of preventable mortality, which is an extremely important point. Prevention is key. So I want to congratulate you on adopting the action plan for the modernization of primary health care. Primary care plays a big role in keeping people healthy and reducing the costs. It's an important step to have sustainable outcomes in the system. The country profile stresses the importance of prioritizing supply of health workers. This is a problem in many places, and there are disparities of access to primary care, health care, so this calls for different staff allocation. Now, through its Recovery and Resilience Plan, Spain plans to invest 2.4 billion in healthcare. This is complementary to 1.6 billion euros that are planned in the cohesion funds. Now, I hope that these investments will support work at national and regional level to improve the resilience of the health systems, because it is only through resilient health systems that the European Health Union can be achieved. Projects like the State of Health in the EU will continue to provide you all with data and analysis for policymakers, and they will help you build a strong narrative on what you're doing. They are very important also at a time when budgets are very, very tight. Now, with all of this, I want to somehow wish you suerte in the implementation of all your projects and all your ambitions in the healthcare system of Spain. For now, I can only say you can be very proud of what you have achieved up to now. Thank you and really good luck.
We are working with high-income countries in a way where we are there both to support and be a shoulder for you, but also to leverage your expertise in support of other less developed countries in our region. And some of the areas that we are working on also under our new country cooperation strategy includes the impact of climate change on health. Just last week I was at our European Centre in Bonn, and it is very clear that this is an area of work where we need to bring all our best brains together to see how we can support our health systems. And of course, antimicrobial resistance and health workforce. Sandra has already touched upon health workforce. I believe we will return to this also in the course of this afternoon. But I'm very pleased to acknowledge that we are working side by side with you in the development of a national health workforce strategy, a crucial starting point in the aftermath of the COVID pandemic, as so many health systems are really struggling. But behind the health system and the backbone of the health system, when we talk about the health workforce, it's not just numbers, it's people, it's human beings like us. And this is why we must start from them. And just a couple of weeks ago, I was very pleased also to meet your Commissioner, Belen, at a meeting that we held in Helsinki, really focusing on the mental health of the health workforce. And I was delighted to learn of the systems that you are putting in place to monitor mental health at the workplace, which will be the key theme for World Mental Health Day on the 10th of October. And of course, in spite of the strains that the system is experiencing, I note very positively the trust of the Spanish population in the healthcare professionals who are doing an extraordinary job. The steps that you have taken and the decision just a few days ago to set up the National Observatory Against Fraud and Corruption is also a very welcome step, building on the highly successful event that was held in May. Why? Because, of course, the trust of patients, the trust of professionals, and the trust of everyone who is funding the health system is indispensable for us to be able to maintain and innovate and continue to invest. And this will be at the heart of the key technical topic on the agenda, the Regional Committee, which will happen in October, where we will present a new and updated health systems framework for adoption and endorsement based on the lessons we have learned from the pandemic and looking forward at the areas where we still need to further develop our health systems. We continue to count, of course, on Spain's support as we move forward into some of these novel areas. So, in closing, I believe that Spain is showing how critical it is to continue to invest in the health sector, but also let us not be naive. We face difficult times. Many countries are facing pressures and fiscal constraints. And also, it is very important to show that even in difficult times, we continue to protect, particularly, the health of our most vulnerable, a point that, again, I will be pleased to touch on later this afternoon, because here Spain is truly leading by example. Because at the end of the day, investing in health is a choice. It is the right choice, and we will continue to stand by your side to ensure that you are enabled to continue making the right choice every single time. Thank you.
Thanks a lot, Natasha. You already highlighted some of the aspects we'll be talking about when we look at the Spanish health systems, issues of primary health care, health workforce, issues of trust, issues of investment. So that's been very, very helpful indeed. And I'd like now to introduce Javier Padilla, Secretary General of Health, also to welcome us to this meeting today. Javier.
Thank you very much. I'm speaking in Spanish, the same as the minister when she arrives. Así que, bueno, antes de nada, excusar la...
Before we listen to the speech by the minister, who will be coming, but will be coming a little later, so I'm going to improvise an inauguration now. I'd like to start by thanking the Observatory as well as the Regional Office for Europe from the World Health Organization and the European Commission for its presence, but not only for its presence here today. Recently, I read a phrase from a scientist called Lindman Murgulis, who brought out the cells theory, saying that life is a symbiotic union and where it allows those who cooperate to have success. So we're trying to explain all progress in terms of competition, but we need to remember that the true progress made in the field of politics comes hand in hand with cooperation. And it seems obligatory to understand that. An obligation where we've found this in the three institutions and organizations that I named. Cooperation with the European Commission, which could be reflected throughout the Spanish presidency of the European Union, where the many of the policies that are being carried out today could show this, but also this will continue to be seen because I think that this is a ministry that is very pro-Europe and shows what the influences are of the policies that are being executed and the guidelines set down by the European Union together with the other countries and which can benefit our progress. And this is a partnership that is being seen through the regional European office of the World Health Organization to put together their interests and our interests. And Natasha has mentioned the platform for primary health, but also the event that will be held in the near future on human resources in health systems, quite possibly this to be held at the beginning of December, I believe. We can talk about how we've created partnerships with nurses and how to configure the skid mix in our health system on mental health of our professionals and also the role of leadership that we're grateful for with everything to do with the evacuation of children in Gaza that need health care. These are interests that are very much aligned, and we will continue exploring this and everything to do with this. As for the observatory itself, and we are very much grateful to Josep, not only now, but also because of the last decades for all the work that has been carried out, and more particularly what has been mentioned by Natasha with regards to the event that was held recently by the Observatory against corruption and fraud in the health system. I believe that this report that is being presented today is a very good example of how to reflect the situation in the health system so that public policies that are adopted are well-informed, effective, efficient, and in addition so that they are put into practice. Just to conclude, because I did just want to be brief here, I want to mention that this report is useful for us on the one hand, to be able to show our pride in the health system and to recognize the structural determining factors that mean that we can obtain good health results, and also to identify those things where there's room for improvement. I think that to move to the next stage is one of our tasks. We've spoken about the same things for the last few decades, and I think we need to do a reset to start talking about other things. I believe the Minister of Health is just entering the room now. It is necessary, as I was saying, to start talking about different things. And the best example we've seen recently with the Royal Decree on Health Technologies that we hope will come into force before the end of the year, and will mean that we will no longer talk about what we've talked about for the last few decades, and we'll be able to put these things into practice and give priority to other elements that will be essential within our system. Without further ado, I'd like to thank you very much for the report and the event organized today and all the work that is being carried out and will be carried out in the future. Thank you, and let's enjoy the session we have ahead of us today.
Thanks a lot, Javier. So what are we going to do now? We have 3 blocks ahead of us. The first block will be talking about learning about health systems, and we'll be talking about the kinds of resources we have available to learn from each other. Javier, I like your metaphor about symbiosis and cooperation. So what we want to do is to enthuse you to more symbiosis and more cooperation in the field of health systems. The next block will hear about the Spanish health system, based on these 2 documents we're launching today. And Minister García will join us with some reflections and welcome on this general theme of the Spanish health system and collaboration. And then we have a panel where we're going to bring both elements together. We're going to discuss what we learned from Spain, and we want to discuss best practices also from Spain, as well as challenges and other member states, where some of these protagonists you already see here will come back to reflect on those major lessons. For those online and those live here, please, those live here, wait for the end for some questions. And for those online, we have a moderator. Please send the questions, and these questions will be addressed to any of the panelists or the speakers that have spoken so far. So, I'd like to now introduce in the second block Ewout van Ginneken, who's going to be, Ewout van Ginneken is the head of our hub in Berlin of the European Observatory. Ewout is going to be the new director of the European Observatory in January 2025, so I'm passing the baton to Ewout. And Ewout is going to be reflecting about our bread and butter, Ewout, the comparisons, the health systems, and tell you what are the kinds of resources, profiles, studies that are there. They're public goods, and we hope you're going to be using them a bit more. Ewout.
Yes, thank you very much. I hope you can hear me well. Yeah. Thank you for that. Well, thank you for allowing me to speak about my passion, which is country monitoring. A very important piece of our work. Let me just go to the start. I will be very brief, but I think because we're all here, because we would like to hear also from, especially from Spain and the other countries as well, but I do like to speak a little bit about why country monitoring is important. So, why should we monitor health systems? To assess the performance of a health system, understanding its structures and functions like financing or the governance or resource generation, delivery. It's really important to have a thorough understanding of how a system works, and for that we really need a very thorough, in-depth description. It's also responding to a need that we see is that we need good, comparative, reliable information. We often get asked, although we have all these products out there, to provide this kind of information, although lots of it is out there already, which I will show. And also, maybe it's good for policymakers to sometimes look at other countries and what they are doing in terms of how they approach certain challenges in the system. My experience with working with national policymakers is often that they're very focused still on what's happening within the country or even their region. It may be very worthwhile to look abroad where maybe similar challenges were dealt with. To do this in a structured way, you really need a standardized template. And on the right, I show a little picture of the template we use for our country, for our HIT series. You need that because you need to gather all the information in a structured manner according to similar definitions, so it's also accessible to you. And even if you then read another country, you know where to find the information that you're looking for. So what is in our portfolio? And I'll be very brief about it. We have the HITs we will be launching today. That's the number one. Those are the most comprehensive, lots of detail on processes and description of the system, which is often information that you want from us. Of those, we produce health system summaries that are shorter and produced more regularly every 2 years. Again, with a strong focus on descriptions and reforms. We have a new series, the Health Systems in Action Insights, which we do together with WHO European region, where we produce smaller descriptions of the non-EU countries in Europe, with lots of information, lots of nice data, telling titles, really easily accessible, quick introduction to a country. Number 5 is the state of health in the European Union country health profiles, which really is now in its 5th edition next year, has been a great success, which we do together with OECD and is commissioned by the European Commission. And Isabel will be talking more about this process. We're having an incredible impact there. Again, very easily accessible, telling titles, nice read. We have number 4, the health and the economy snapshots, helping you to make the case in your countries of the contribution that the health system can deliver even outside the health system. And we also have the HSPM, the Health Systems and Policy Monitor, where we provide more topical, more timely information on updates in countries and even small policy analysis. And I will get back to that later. We also have a new strand of HITs where we don't look at a particular country, but at a particular field. So we have them on pharmaceutical regulation now, oral health, which is of course was always a huge challenge in Spain as well, and healthcare and care data, where we really look at various countries and in a systematic manner describe how this is organized in those countries. What we realized over the years is that for timely information, you really need a network, and we write all our products together with people from the countries. That is really important. If we would write them ourselves, we would not have the richness and the detail that only people from the country can provide. So we've been building up a network with whom we do this together, and that's the HSPM network. You see a picture on the top of them. They're all academics working in universities and research institutions. We have annual meetings where we discuss health reforms and opportunities to collaborate. And they help us maintain this website where you can find all this information. So using the QR code, you can access and have a look. You will find smaller updates, you will find the latest profiles, everything is accessible there. There's even a comparative function where you can say, okay, how is primary care organized in these countries, and it will give you those results. So what can country monitoring be used for? Of course, examining different approaches, that's an easy one, but also institutional framework description, the process, content, implementation of health policy. We often get questions, how do other countries formulate health policy? Not even the content of the reform, but how do they do it? It can highlight challenges that require more detailed analysis. It's often used as a tool for disseminating information on health systems. Also, as an exchange of reform experience between countries. When we do a policy dialogue between 2 or 3 countries, we bring them along so that people can check them beforehand, and that makes the policy dialogue way more effective if there's already an understanding of the other countries' health systems. They are used a lot also for comparative analysis and research and teaching, so all of these products are cited quite a lot. They have been very good at identifying emerging trends, which we then can pick up. For example, something like private equity, which is a huge concern in many countries, was picked up in our monitor, and then we're doing comparative research on it. Lastly, country monitoring is a key for performance assessment. And in this little article we wrote for the bulletin, we explain why it's important to do a full health system description before you do an HSPA, and that it's really important not just to use quantitative data, but also really the qualitative data, which is very good at explaining processes and interpreting data, whereas if you only focus on the quantitative, it may not give you all the answers. And that is a development that we are also now in at the moment at the Observatory, where we see a convergence between health systems monitoring and HSPA, which are basically achieving the same goals. And this is our framework, which we have together with WHO, that shows all the interlinkages. I'm not going to go into detail, it's too complex for here, but it shows the interlinkages between the different sub-functions and the intermediate objectives and the final goals. And for that, you need that qualitative information from country monitoring, obviously. Just an example, and then I'll stop, is something like effectiveness of a health system. If you see that, for example, avoidable mortality is very high, you may start to think it's maybe a quality issue, but if you dig deeper in our model, you can also end up that it's maybe a financial issue, or rather a governance issue, that the system is very fragmented, and that gives you other, what we call performance pathways that help you explain what's going on in the country, and then you can also develop good policy. So that is a process that we're in now, that we will start to do more of this, the marriage between country monitoring and HSPA, and I'll stop right here, and I look forward to discussing this more with you. Thank you very much.
Thank you. Thank you very much, Ewout, for putting on the table many of these products we do with the European Commission, products we do with WHO, products we do with member states, and showing its real practical policy value. I always worry that we are called sort of analyst academics writing books. We are about trying to support policy making. And I like to introduce Isabel de la Mata, Principal Advisor at DG Santé, to talk about a particular series, the State of Health in the European Union, which is already in its third. Last year, in December, we launched these files, actually. In its third generation already, with lots of interest from our member states or our analysts. So if you can tell us a bit, what is the state of health in the European Union? Where do we find? What can we learn out of it?
Buenos días a todos.
Good morning. I'm going to speak in Spanish, and then I'll speak in English during the panel, because I think it's strange that here, where I've been for 13 years, that we're all talking in English. Anyhow, good morning to all of you. And Ewout has explained exactly why it is important to work in health systems and on information on health systems. And what I'm going to tell you about very briefly is about the part corresponding to us, where the European Commission is working on, which is the state of health in the European Union. I believe that the presentation has gone from the screen. Perhaps it will come back. Anyway, in any case, the State of Health project in the European Union that has been underway since 2017 is a cycle that repeats itself every 2 years, and we start again. And it is very important for us to announce that in November, or end of November, we will have the new report on the State of Health 2024. We are working on the one for 2022 now, and in 2023, which is part of this cycle, what we do is always launch 2 types of products or documents. One are the health profiles from the different countries, from the 27 member states, and this changes to 28, 29 perhaps throughout the years. These figures have changes depending on the size of the European Union, and we include those countries from the European area. So as for the specific country profiles, the synthesis report that was called the companion report beforehand, but it seemed that calling it the companion report was really making it less of a category in itself. And so this is the model that I brought with me to show you in terms of the documents from the different countries, the state of health in the different countries. And it was a question of drawing up a new a new document of 20 pages long, drawn up by policymakers or for policymakers and anybody else working in the health system. And that was a quick reminder of what the main challenges were and main strengths of their own health systems. And then the synthesis report allowed us to do a cross-cutting comparison between how each member state was doing versus other member states within the European Union, of course. In each synthesis report every 2 years, in 2022, 2023, and we're already creating that one, the one for 2025. Well, the one for 2023 focused on how the health systems responded after the COVID-19 crisis. This report has two parts to it. The first part is where we have 3 work areas, and we will look to see what the situation is of each country in each of those 3 areas. And the second part are the summaries of the different countries. These are the 3 areas that have been used in 2023, which are mental health, it's closing health gaps, or to see how we can actually contribute to ensuring that these gaps don't increase. And the third part corresponds to investments towards resilient and accessible health systems that can respond to the different problems. The last big problem was COVID, but there are other problems that also appear. In fact, the state of health in 2024 in the 2 areas that we're going to focus on are health workers and the impact of longevity on health systems. In these 3 areas, I just want to convey a very brief message. The first one on mental health, and that is that COVID-19 in reality had a huge impact on individuals, but also the reforms that have been adopted in the different health systems after COVID have had a huge impact. Apart from 1 of every 6 workers considering they have problems, something is important is that 1 of every 2 workers considers that if there's a health crisis, their work and health will be negatively affected. So there is a need to do away with this stigma. It's of great importance. The second message, as there are a couple of messages for each of these areas, is that the health inequalities have grown after COVID in most member states. And also health needs that haven't been covered have increased since 2021 to 2023. From 1.7% to 2.2%. So we're not doing very well at all. We are actually moving in the wrong direction here. The third message is, or at least the third area that is on health investments. And here there's an important message. Impact doubled, prevention of 3%, which was the figure that we'd been resorting to. It's gone to 6.2%. And basically, this was thanks to the vaccinations, but also for the few countries where we do have data for 2022, unfortunately it dropped again since then. So we thought that this was going to represent an increase on a one-off basis, but it seems that the data is telling us the contrary, and that is not at all good. So therefore, this is repeating what I already mentioned beforehand, but it is important to say that we're coming to the end of this commission. As you all know, we're awaiting the new commission's creation, and it is an opportunity to go through a thought process to see what it is we've achieved, to see what it is that we have as challenges ahead of us. The European Commission has already said on several occasions that it is committed to strengthening the health systems, competitiveness in the long term, and also to building a an economy that is based on responding to structural changes and challenges. And then something that is very important is that cooperation is essential. And all 27 member states and organizations agree on this, particularly the World Health Organization, to attempt to rebuild what the pandemic did away with and where so much time and effort has been placed in to be able to go back to levels from before then. Thank you very much.
Muchísimas gracias, Isabel.
Thank you very much, Isabel.
Themes. It shows that it's not only about country profiles, but it's about comparisons. What the report that came up with health, the health workforce, mental health, an issue will come talking about Spain, another country running the panel, inequities as well, and health investment. And thank you very much. A personal sharing here, a private personal sharing, when Isabel and the Commission pushed the observatory on the OECD, and they said, you have to do a country report of 20 pages. We said, no, it's not possible. Then they gave us around 60 pages of comments of our template, had to be 20 pages. But indeed, Isabel, I hate to say it, you are right. We managed 20 pages analysis, which is sharp, comparative, and lots of learning. So I'm very proud you push us, Ewout, like me, and we are very proud that we had that pressure to try to synthesize the analysis of a system in a balanced, in a rigorous, in an analytical way, in a policy relevant way. So we're very pleased and looking forward to the 25 series. Well, now is, as they say, the British say, the proof in the pudding is in eating it. So now my colleagues, Cristina Hernández-Quevedo and Enrique Bernal, have the difficult job, first of doing the actual work, and then presenting it within a limited time that we have today. So how does the Spanish health system look? Cristina Hernández-Quevedo is a technical office in the European Observatory, and then I'll introduce our star later on, Enrique Bernal. So Cristina, tell us what we learned from these two documents, from so many hours of work, and that in just 10, 12 minutes each. That's a difficult thing. Let's prove that we are able to communicate. Cristina, thank you.
Hello, thank you everyone. Es un placer para mí estar aquí.
It's a pleasure to be here.
Enrique Bernal, an assessment of the health system in Spain, an overview, some key findings and lessons. And this is the evidence that we are going to use in this presentation. Is taken from the health system review for 2024. This is just available since this morning. And I have to thank all the authors that have contributed to this publication. They are somewhere here as well. So thank you so much to all the team, to external reviewers, to the ops team that has made possible to have it land today. And also we are going to have the state of health in the EU, some evidence from the country health profile that we are presenting officially here at the ministry, and that gives us the European perspective. So we are going to gather evidence from both publications in our presentation. Just to give you an overview of what we are talking about and a bit of a structure, so we thought it was relevant to give an overview of the health system, starting with health status, following with organization, health system financing, human resources, provision of services, and then Enrique Bernal will follow with the recent reforms and assessment. The idea is to end up, and the important thing is the panel later on the lessons in the European context and the way forward. What can we learn from other countries and what other countries can learn from Spain? So I will try to be as brief as possible. So to start with a positive note, so we have that Spain has the highest life expectancy in the EU. It was in 2022, 83.2. This was far from the EU average of 80.7. Of course, with the pandemic, there was a decrease in the life expectancy, but this increasing trend has recovered, and actually super latest data from the European Commission says we are now at 84 life expectancy in 2023. So we have gone back to pre-COVID levels. The issue here, of course, there is a gap, a gender gap between men and women, with women 5.5 years with a higher life expectancy of 5.5 years compared to men. Also, COVID had an effect on mortality for men, so that increased the gap. We have in Spain also life expectancy at 65, higher than the EU average, and also life expectancy for those 65 plus without activity limitations, so it's higher than in Europe. However, the proportion of people aged 65 that report chronic conditions in older age, is more likely that in the European Union. In particular for women, they are more likely to report chronic conditions and also limitations in their daily activities. And going now to risk factors and lifestyle behaviors, so we know that a third of all deaths in Spain are attributed to risk factors. Actually, this is a bit smaller than the EU average of 39%. So, but in this graph, this is from the state of health in the EU, and you will see the farther you are from the center, the white area, is that there is room for improvement compared with other countries. And we see that although tobacco has decreased over time with all the policies implemented to regulate its use, is still the main cause of avoidable mortality. Then there is an issue here, you can see in the graph that there is room for improvement for alcohol consumption in adolescents. Sorry. Then obesity and overweight remains an issue for children. So you have there 39% of children aged 6 to 9 in the period 2018-2020 had obesity or overweight. And I think one relevant thing from here, from risk factors, is the inequality. So we see differences by educational level. So for example, in the case of tobacco, of obesity, for example, for adults, is 10% for those with highest level of education and 21% for those with low levels of education. Similar for the consumption of fruit and vegetables, you can see these educational inequalities, and this at the end of the day, it can transfer into inequalities in health. So we thought with Enrique that it was good going now into the health system itself to give a snapshot for those maybe online that are not aware of the health system. So we have a decentralized health system with national coordination. We have health competences in the health system transferred to the autonomous communities. The overall coordination is under the Interterritorial Council for the Spanish health system, where we have the Ministry of Health and represented all the departments of health of all the regions. It's a system that provides universal coverage and primarily financed through general taxation, and the care is provided mainly in the public sector. Private sector actually is an important player, and we'll see some figures later on, but it also provides voluntary health insurance schemes to individuals. In Chapter 2 of the HIT, you have an extensive information on the organization of the system, all the organigrams, etc., that you can see. Now going to give some highlights on spending. So public spending is the main source of funding of the Spanish health system. And actually there has been an increasing trend in the percentage of GDP devoted to health, and this was linked to the pandemic as well. So in 2021, 10.7% of GDP was spent on health. There was actually a dramatic increase given the pandemic, and you see that in the graph, UK and Spain were the strongest increases. Still, for the level of spending as a percentage of GDP, Spain is below other national health services countries, no? Like UK. Also far from other social health insurance countries such as Germany, but in line with other countries such as Denmark. So it's a bit in the middle. And although public financing is the priority, there are out-of-pocket payments that represent 1/5 of the total health spending. And you can see there how out-of-pocket payments correspond in Spain to 21%, while in the European Union the average is 15%. And voluntary health insurance has increased as well in the country, so reaching 7%. And in the EU average is 4%. The out-of-pocket payments are covering mainly pharmaceuticals, some processes that are not included, dental care, and optical care. But we have to say that there have been some exemptions put in place, the latest in 2020, that have reduced the burden into the population. Now, regarding the number of practicing medical doctors, they are significantly above the EU average, and they have been increasing over time. The number of nurses has also increased over time. However, it has been seen that there are future needs of health professionals that may not be covered. So there is an issue of shortages of human resources, mainly primary care doctors in rural areas. Also, what you can see here, and I wanted to show this graph because it's widely used, that you see that for doctors, Spain is in the highest position, but for nurses, it's below the EU average. And this is because in the data, we are not capturing the nurses' assistants, that they have a similar role than nurses in other European countries. Now, in terms of provision of care, so I'm just saying like the latest developments, so we can see that the priorities have been on public health, primary care, and mental care. Of course, these new national plans and strategies have resulted from existing challenges, also with the pandemic. And so we have, for example, for public health, the 2022 National Public Health Strategy. For primary care, we have the 2019 Strategic Framework for primary and community care. For long-term care, I wanted, even if it's new, but I wanted to say is in place the 2006 National System for the Assistance of Dependent People. For mental health, we have our mental health strategy since 2022. And for dental care, following the unmet needs in dental care, we have the 2022 dental health plan to increase the eligible population and also the benefits basket. So I leave you here with the key messages. So we have highest life expectancy in Europe with certain inequalities in lifestyle factors. Public spending is the main source of funding. Out-of-pocket payments remain high, and voluntary health insurance keeps growing. We have the health spending as percentage of GDP, also per capita has largely increased due to the COVID-19 pandemic. Of course, there are shortages of some medical specialties that is important, especially for family doctors, and that priorities have really followed the COVID pandemic and the consequences, and they have focused on primary care, dental care, and mental health. So I leave it here. I follow with Enrique Bernal, and thank you very much. Thank you.
Many thanks, Cristina. Not easy that you managed to give us a good sense of the is it working? Yeah.
I think so.
Spanish health system and the key messages. I'd like to introduce now the lead author of this work, who I believe will be thanking as well the other authors of this work, Enrique Bernal-Delgado, who is from the Aragon Institute of Health Sciences, the national lead institution for Spain. We've been working together for many years. Congratulations for your baby, to you and your co-authors. And you have the more difficult task to talk a bit, push more on the performance side of this health system. And more importantly, as importantly, what are the lessons for other countries that we're going to be debating in the panel? Kike.
Thank you, Giuseppe. Let's try. It's not that easy, though. So, in 15 minutes, really nutshell, some snapshots, and allow me that I, pick some of the actual findings, maybe to foster the debate afterwards. You will see the slides on top. Title is sort of a statement, the lesson, and then some facts. And then I will arrive in the lessons and try to figure out what we can learn from others as well. So in this first one, we can say that since 2018, there is very concrete regulatory steps towards effective universal coverage that can be seen in this slide. So they affect to the breadth, to the depth, and to the scope of the coverage of the system. And you see then that the change in 2018 of the basis of entitlement back to the condition of resident. You have those new exemptions from co-payment in the 2020 law, budget law. That actually was benefiting 7.3 million people into 2024. In the scope, many small but important changes, but maybe the most important is we have seen the strategic framework for primary and community care and the action plan that is been now in the implementation phase. The strategic framework for mental health and action plan, it responds to the deficit that we have in mental health care, and also the organic law for the regulation of euthanasia. Of course, there are many others, as I say, hearing aids for more people, the flash monitor system for diabetic people, expanded out to other groups, etc., etc., etc. But these, to me, these are the main ones. Another statement. Well, met needs for medical examination remain low, and the difference across income quintiles remain even lower, and are improving over time. In medical examination, you see Spain down there, is the oranges, improving, not differentiating between income quintiles. We cannot say the same for dental care, and presumably not the same for optical care. There are the underlying causes for not accessing dental care are the same for optical care. It's income, households financing, household budgets. So very likely will be the same. We don't have numbers for that, though, because are not in the statistics, in the national statistics. Third statement is about financial protection, and all my colleagues around are surprised that having 28% in the latest numbers, 28% of private financing of the system, we keep financial protection high, particularly for those poorer households. And there are many reasons. Actually, we are one of the ones. These are 2019 data. You see the arrow there. We are one of the ones with the lowest problems in terms of financial protection of the poorer households. Well, we have very good to say. I mean, we can compare, but very good results in terms of those avoidable mortality indicators. So both preventable mortality and amenable mortality, treatable mortality, also said. You may see, though, that this figure and the past figure are shown in Spain quite at bottom, so low rates. In terms of treatable mortality, we are improving over the years. Maybe because of the COVID-19 pandemic, we have not improved this time in terms of preventable mortality. But still, we are in this part of the graph that improvements are not that easy. Same happens with financial protection. You will see later in the next slide as well, quite a big of a problem for that. So we are doing really well. Improving will require disruptive policies, I guess. This is the message in the end. Here, value for money. With a relatively low expenditure on health, you see on the x-axis, you are seeing the per capita expenditure on health. We get good results in terms of treatable mortality is on the y-axis. You see again We are down there in the countries spending the same, we are the lowest. We may improve it in terms of treatable mortality, but to improve that, you see all the countries are flat. So we may need disruptive policies for the future. Less satisfaction, though, with the National Health Service. And there is a quite a notable finding here, which is that it takes longer to get an appointment to primary care. In this graph, blue bars, darker is 2023, the light ones are 2019, sorry. And on top, you have good or very good emergency care, good or very good inpatient care, good or very good primary care attention. You see there is less satisfaction, though we are over 75%, and in the case of inpatient care and primary care, over 80%. Still there. Overall, though, those interviewees say that the SNS, so the National Health Service, those that see this working well or very well are reducing over time. Now, actually, the difference is higher. It's 55% of them, when in 2019 there was more than 70. In reddish, interestingly, reddish average times or median times to get an appointment. In the first one is average median wait time in primary care. In the second one, overall satisfaction with the SNS, with the National Health Service, out of 10. And you see that now to get an appointment takes much, much, much longer, 9 days median average. When in 2019, 50% of people got an appointment in 24 hours after asking for that appointment. In 2023, 70% of people didn't get it. Well, let's go for the lessons, and these are my last 3 slides. I don't know, Josep, I'm on time? Okay. So how to read these 3 slides. On top, the statement. First box, findings. Second box, lessons that we can learn, or where to put the accent on. And then in the panel, we will have the opportunity to discuss on it. In terms of effectiveness, so is effectiveness, is equitable access, is efficiency, the 3 slides. In terms of effectiveness, well, the National Health Service has proven to be effective in terms of low rates of avoidable mortality, treatable and preventable. And my interpretation, our interpretation as authors, is that the current design, the institutional design, is still working. Is based on universal coverage, free of payment at the point of care, is financed by taxes, with a mix of taxes, some regressive, some more progressive. There is a strong gatekeeping, so primary care here plays a big role. And the distribution of resources is population-based. And then there is quite balanced public-private provision of services. So our interpretation is that this design works and can remain. However, second box, well, these access barriers to primary care in the long run will provide bad result in the end for us. Second point is the shortage of professionals in some areas that is expected to increase in some of those areas. Areas are rural areas, but areas are public health, primary care. Areas are also those professions that may work more on the needs, current needs of the population. I'm thinking of physiotherapists, I'm thinking of psychologists, for example. Okay, second lesson. The National Health Service design allows, at this point in time, allows the mitigation of access inequalities. We've seen that this financial protection, right? And even though we have this high toll of out-of-pocket payments, this is not translating to the burden of the poorer households. This is a fact, and we can contrast it. We can see it as what the sign of the co-payment is not that strong. I mean, even though it's proportional, slightly proportional, we have caps. We have a lot of exemptions, as I said earlier. So this design of co-payment may work, but also the fact that the system is financing as the rest of welfare state services, as social care and education. The way we are financing these three systems helps a lot to reduce the risks for these families. But despite of this, we all know that poorer households are more exposed to unhealthy lifestyles. Life expectancy for them is lower. Unmet needs in dental care and optical care affects them the most. Self-reported health status is higher in those families. So there is a lot of room to work in. And I guess we may discuss about that in our panel. And I have 3 more minutes, my friend. And then, what about efficiency, overall efficiency? If you think of this discourse that we are having here today is quite macro level. It's not micro level. It's more macro and meso than micro. But in terms of overall technical efficiency, we've seen that figure, right? With expenditure per capita rather low as compared with the good results, low treatable mortality. Well, the fact in the point of the expenditure, the fact that it's a highly regulated system, there is an administrative distribution of the resources. The workforce is mainly composed of civil public servants. And then you can constrain the budgets in the salaries and the unit prices for the goods. So very likely, the way you are doing this, goes in the direction of restraining the expenditure on health. But you have a very good workforce working for the system, for the public. So this could be one of the main reasons for that part. But, and this is the last point, still there is a lot of room for improvement in efficiency. So we are now reacting to the needs of the population as if we were in the 70s or the 80s or even before. Now our population is living longer with more needs, different needs. We don't need more surgery, maybe. We don't need more care. So there is a point here on how to implement policies to put the resources needed in the needs of the population. Of course, we need better coordination with social care. Across level, we always talk about primary care and hospital care, but we need to start thinking of social care. And we witnessed the strong crisis we had in the COVID pandemic, right? And there is a specific point on mental health care. We need more coordination with these other areas, particularly with also community resources. If we think that the reform on mental health needs community approach, we need to put more ideas on how to develop the community approach, liaising with these community resources. And then, last but not least, of course, we need policies to reduce low-value care provision. I mean, you all know about the atlas of variations in medical practice. The evidence of wide variations and warranted variations in medical practice is actually a symptom of the provision of low-value care we cannot afford for in the future. And thank you very much. This is all from my side.
Clear, very clear lessons for reflection, lots of questions it raises, not what you said, but what it raises in terms of wanting to learn more. And in a minute, we'll have Kike and colleagues on the panel to thresh out a bit more these questions and these lessons. Also, many, many thanks to the co-authors of both the Health System Review and the Country Health Profile. Now I have a particular honor to welcome Minister Mónica García. Mónica, thank you very much for hosting us today. Thank you for the excellent collaboration we've been having with you in recent times, for a long time, since you are leading the ministry. And some reflections. Are you happy, Mónica?
I am very happy.
But work to do, right?
I'm always very happy. Thank you very much. Bueno, buenos días a todos.
Okay, good morning, ladies and gentlemen, and I do apologize for not having been here to begin with the presentation, but authorities, authors, attendees, teachers, ladies and gentlemen, and I see that there are great specialists in this field here, so it's a great honor to be here in the inauguration or the launching of the health systems in transition. I'm very grateful to the authors of this report. Thank you, Enrique Bernal and Manuel Rigao, Rosa Urbanos, Juan Oliva, Daniel García, and thank you for the contributions to Daniel González Valcárcel, Repullo, and Zapata. Thomas Zapata, whom we know as Zapata. And also thank you hugely to the European Observatory for Health Policies, represented by Josep Figueras. Thank you very much. It's always a pleasure and an honor to work with you because of the constant efforts in generating this type of reports. Also the European Commission, to Sandra Galina, of course. It's a great honor to have her here virtually. And Isabel, thank you. And also thank you to the Deputy Director of National Health System, Natasha Asopardi, for this good work that we have done jointly in the last few months. It is a true honor to be here in what I hope you will consider your home, and it has been for the last 2 months. The Ministry of Health, with this poster on this subject where all the talent, high-level experts are represented whom I admire and respect. I think that I must point out that in the team we are huge fans and supporters and love this type of reports. So I'd like to begin with what is obvious, and that is that we have a national health system which makes us truly proud of our country. We also are very much champions, and thank you to the General Directors and Secretary of State, love our national health system, not only as a health system that looks after, cures, and alleviates pain, but also as a health backbone that redistributes health, because one thing that's important here is our health, and with a coverage that is practically universal. Our health system represents very well these social aspects that we defend, justice, solidarity, equity, that represents most of our society. And we have a witness here of the huge progress that has been achieved since that health law of 1986 approved by Ernest Jung. It is a robust system that has managed to achieve very high levels of well-being that are a benchmark, not only in Europe, but also in the whole world, with a life expectancy that's one of the highest in Europe, and with health indicators that are true, tangible proof of the success of our model, not only our health model, but also a social model that we are always going to defend based on a welfare state, despite those failed attempts of relegating our health and social welfare model to the back of the queue, and in simply making health something that can be traded with. So there's been a great effort made since 2018 to date in order to try to recover, update, and to focus in more depth on all the progress achieved as a national health system in recovering our universal coverage and in strengthening our primary health system, which is an essential pillar, but we don't want this to become a pillar that will become a burden for us. And also in extending this coverage of our national health system through extending the services we offer. Nevertheless, we can never sit back on our laurels. We need to continue making progress, strengthening our work we do, and we feel proud of the fact that we will not give up and will always continue to try and improve upon ourselves. And we've seen some tables and saw how or what position we were in versus Europe and how we were in a good position. I always wondered why we weren't the best. Well, that is what we aspire to. That is our ambition. We want to see the best in terms of coverage. We want to be the best in everything to do with access to our public health system. And I think that we are a benchmark not only in Europe in that sense, but in other areas too, in our fight against tobacco, for example. And I think that when we have brave, progressive health policies, this means that society can make progress and the health of our population improves, but also we make progress as a society. And those reports, therefore, are essential. The report that you are presenting today, or that we are presenting, makes us look in the mirror. It makes us do what is done on a daily basis in the world of science, in the practice, and it makes us do an assessment and continuously improve ourselves, improve our public policies, and improve our national health systems. This is continuous improvement, continuous learning process, and this is why this HIT report is a compass for us. It sets the way forward towards where we are going, and it underlines those gaps that we have to close in order to have a stronger, more robust and equitable system and that is more resilient. There are a lot of things that have been touched upon in the report. Some of them have cropped up today, and I'm sure a lot of them will be debated upon, not only today, but hopefully we will continue to debate on this in different fora whenever we have the opportunity to do so. I believe that this ministry has made an effort, and I think that we do really have to put these things on the table, continue improving, particularly in three areas. One is in terms of universality, the other is in primary health, and thirdly, extension of the oral and visual health. And going now to the universal health system, we feel very proud to be a country whose health system or health is practically universal. There are just a few things we need to achieve to be fully universal. I say there are small things, but I'm referring to some people that are still not covered by the system. And this is why we want to adopt the universal law so that we can put into practice what we learned throughout the pandemic, because nobody is safe if we're not all safe. And this is why I'm just going to convey a political message amongst our health messages, because I truly trust policies in a context where we try to, where we point out a lot of immigrants. It is essential to defend our health system and ensure it is for everybody. Our universality is good, it's human, it's efficient, and it is the flagship of those values that we want to promote within our primary health system. And we need to repeat this. True security is not that which lifts up barriers against racism. True security ensures that all people receive the necessary care they need. So therefore, some people are talking about racism and exclusion. So we actually should lift our head up and say universal coverage is one of our main strengths. So against racism and xenophobia, we need rights, human rights, civil rights, and constitutional rights. There's no doubt that this is one of the main achievements in our countries, and I think that there are other countries that look at us with envy, and we will work tirelessly to be able to strengthen this pillar in our society. Secondly, I wanted to talk about primary health. We've spoken about this on many occasions. It's said is the entry into our system. I say it's at the heart of our system. And if we now go to politics again, during the elections in the United States, they're debating upon whether health is a basic right or not. Well, Spain can feel extremely proud to be able to offer quality primary health care to all of its population, regardless of what their economic situation is. The attempts to strengthen the system in the last few years have been complex. There have been many challenges and many problems, of course, but we are aware of the fact that we need to ensure that those challenges are overcome and worked on amongst us all. Some have cropped up, the lack of professionals in some areas, particularly in rural areas, responding to demand and coordination between different levels of assistance or care. So that access to primary health we knew that we were in a privileged position in that comparison between countries. But we do see we have to continue improving. After the pandemic, there was a before and after, and there's been an increase in demand. There's been an overload of the system, which means that patients haven't had access to a first appointment with their GP, which is one of the indicators that has worsened. And this means that if you're given an appointment in a week's time to see your GP, who knows you, who does the checkups and knows exactly what your health situation is, your personal, family, and community situation is, well, this is a way to break the relationship between your GP and patients. People who spend a long time with doctors and nurses that have heavy workloads break something that is truly sacred in our profession, and that is that personal relationship that we have with our patients. So for this reason, we are drawing up a primary health action plan following the strategy that was created in 2019, improving upon it and comparing it to previous plans and putting those best practices on the table that we've seen not only in our country but also abroad. And finally, I'd like to refer to the need to use the portfolio in our visual and dental health to close those gaps in our access to health system. Nobody should choose between seeing correctly and being able to survive on the money they have till the end of the month. And the spending on teeth and vision is one of the greatest expenses of people. So we're trying to improve coverage in these areas to offer a comprehensive service. The report talks about many other challenges that we will mention during the debate, and I hope that we will touch upon these in different fora too. But to conclude, the achievements in our national health system are directly proportionate to the ambition to face up to those challenges that we have ahead of us. The capacity to face up to those challenges will depend on our will to adapt to these, and I think that this report is an essential tool to help us in this process. Thank you very much to all those people and institutions in drawing up this report. And to conclude or to finish, finally, I would like to recognize the great work that has been done, and it is an honor to give this recognition plaque to the director of our friend Josep Figueras, who is leading this observatory, and also for the collaboration and honor that it has been to have worked with you throughout all this time. Thank you very much.
Wow. Well, it's not easy to take me by surprise after all these years, but Minister, you took me by surprise. I wasn't expecting that, and thank you, thank you. I'm not sure how much deserved, but I'll take it with a lot of pleasure. Thank you, Mónica, García, Minister. One, because you're proud. One, because you're proud and you should be proud of how much you manage, but also because you're humble and ambitious. You say, more needs to be done, and I want to do more. And it's exactly what we want to do in the panel. If the panelists can join me now. We're going to talk about achievements, but we talk about humility. We're talking about how much we can learn from Spain, how much we can learn from each other. And we have here that were here earlier that will be reflecting on these lessons, moderated by my partner in crime, Pedro Guillón, Director General of Public Health here in the Ministry of Health, and myself. So we'll give you a microphone in a minute. So otherwise, I'll take over. No, you'll get a microphone in a minute, I'm sure. If the organization can bring a microphone for Pedro, who will be co-moderating with me this session. So I already introduced you, colleagues. So what we're going to do now is be very disciplined, something I'm not. I'm never disciplined, but I'll be very disciplined today. And we'll be taking your three pillars, Kike. I like your pillars very much. So Kike talked about effectiveness, Kike talked about equity, and talked about efficiency. Our three pillars, which we're going to be addressing today. Obviously, many of the reforms we've seen in Spain some of the achievements and challenges have to do with these three dimensions of performance of the health system. You cannot compartmentalize that much. Let's start with effectiveness, and we have all lots of questions. Please continue on the web and live, to think live about the questions. I believe, Cristina, you're monitoring the web, and you'll be telling us what kinds of questions we'll have for our panelists. I think we still haven't got a microphone for you. Someone is blocking you. So, Kike, let's go to effectiveness. It is remarkable, really. These low levels of avoidable mortality, preventable mortality, this high level of life expectancy. But also we have some concerns. Why is it that still satisfaction seems to be as high as it should? Mm-hmm. Is it increasing expectations, Minister? What is it? And there are other worries about health workforce and access. You told us that were reflected in your statistics, in your survey, and may threaten these very high levels of effectiveness that we have in Spain. So could you elaborate a bit more on that?
Yeah, and actually it's about the organization. It's not about the scientific quality of the doctors, the nurses, and how we, and our technologies. We are well resourced about that. It's about organization. If you allow me, two things to highlight here. One is primary care. When we talk about primary care, we have to talk about accessing primary care. It's bad news, really bad news, to have this length of this time of waiting time for people to get access to the first appointment, not to a follow-up visit. This is one thing. And the other thing is, when we talk about primary care, I would talk about fragmentation of care. We're putting much effort, much more ideas on how to resource primary care, but we're not thinking sufficiently of how fragmented care is, even though by design we are an integrated care system. So these 2 points to me are the key points to keep and improve those good levels of treatable mortality and results in general.
What about health workforce? We do have a challenge as well with family practitioners. The Minister was raising that. It's been an issue that the Ministry is concerned about. Javier, Pedro?
Mm-hmm. There is...
will that eventually affect our access and our high levels of effectiveness?
To me, there is a divide between the planning of the undergraduates, so the graduates from medical schools, nursing schools, psychology schools, etc. The vast majority of them will be working within the public system, and even though that there is no connection between the two systems. So this coordination actually is part of the problem to me. Of course, we are now increasing the number of undergraduates, 7% a year, whatever. But it's not just increasing, it's coordinating, planning long run, what we need, what professions we need. Because the population health needs are changing at this point in time and will be changing in the future. So both things are true.
We'll be back to these issues, right, Pedro, later on issues of skill mix, as well and integrated care. Pedro.
Yeah. I would like to move to Natasha right now, because we have spoken that all the primary health care and the health workforce in general, we have some problems not only here, but globally, with an international perspective. We have challenges in retention and get recruitment of medical doctors or health workforce and primary health care in particular. So I would like to ask you about what are these lessons and challenges that can be drawn with the WHO health workforce framework.
Thank you very much, Pedro. So let me just start by saying that never have we had so many health workers. But in many countries, what we see is then when you start looking at the proportion between primary care and specialists, this is going down for many reasons. But here we are today to talk about the solutions. And in the framework for action, which you kindly referred to, Pedro, which was unanimously adopted by all 53 member states last year, we really try to bring together that there are 5 sets of actions that need to be taken. First and foremost, we put the health worker at the heart, which means we need to do something more for our health workers, for their mental health and well-being, but also we need to make sure that ultimately even their salaries are fair and justified. And of course, it's always complicated, because on the one hand, we say that the Spanish healthcare system gives us very good value for money. On the other hand, we are facing fiscal constraints. On the other hand, there is pressure from the health workforce for fair and just remuneration. This is not easy, but the one thing that we need to do is that we need to keep looking at the data, looking at the comparisons, and placing the human being, the worker, the workforce, particularly given that it is a very highly feminized workforce, we need to bring that lens in. Secondly, we need to understand that the demography is what it is. And so we need to look also at the digital transformations that can be done. And here sometimes in some countries we find some resistance from the health workforce too. And we need to understand this, and we need to make sure that our digital systems work for the good of the health workers that are using them. Third thing, the education. You said very rightly, Enrique, that sometimes we have the educational establishments planning the numbers without really talking to the service delivery planning. In WHO 5 years ago, the first thing that I did was join the health service delivery and workforce units together. They are headed by your compatriot, Thomas Zapata. Why? Because we can't leave the planning just to the educational establishments. We need to bring the epidemiology and the service planning into. And then, of course, at the end, there is the governance, the planning and the forecasting, and the way in which we bring all of this together. Is it possible to do something? Yes, you have embarked. You've embarked on your health workforce strategy. You're not alone. Latvia has also made steps, Malta and Ireland, all taking all these 5 pillars into account, because many times countries focus on one of the pillars, and we're saying, no, you have to do it all. Second thing is, if we want to really assess the performance of our health system, the framework provides a lens to do it. And this is what Estonia has just done, actually. It's diagnosed that health workforce is a key bottleneck in improving performance, and applied our framework to look at the performance. But then we also need to be mindful that there are some things that are quick wins, such as taking steps to really prioritize the health and well-being of the workforce and to understand their needs. Young professionals working in rural areas, it's a challenge. We need to talk to them, to engage with them, to try to understand what could help them to be there. And this could be sometimes also being linked in better to larger centers, not having that sense of professional isolation. It can be very threatening when you're early on in your career, having that responsibility. So we need to go behind the numbers, really to work with the people and look at them too. Will the solutions come quickly? No, they will take time, particularly if we're going to be focusing on data, forecasting and planning. We are going to take time to see the fruit of our results, but better start now rather than waiting to be later. And let's also be planning not for yesterday, but for the epidemiology of tomorrow. And I think one of the things that I heard time and time again was mental health, for example. I think over there, the needs are outstripping the supply in every single country. And in many countries, mental health now forms up to 30 or 40% of consultations. So we cannot afford to ignore that. I know you've asked us to be disciplined, and I've said a lot, so I'll stop here.
We'll pick that up later as a key issue as well on integrated care and efficiencies. Natasha, you and I were a while ago in a meeting where we, after a while, went up concluding that we need to have more babies as well, increase our fertility ratio, or use AI. Just a bit of a joke, but a bit of a serious issue. And perhaps, ministers, you were saying how we steer that migration, because we may need migration unless we increase our fertility ratios. There was this data, which I'm not sure is true, Ewout, from Germany, about 1 of every 3 newborns has to work on health and social care to take care of the needs of all. Some of us are getting older. That's it's a very, very complex statistic. We need to be thinking about that. Isabel, one thing the European Commission is doing is a lot of thinking, as well as WHO, a lot of support to member states, and particularly in the area of the health workforce, from planning, forecasting together, quality standards, mobility, lots and lots of initiatives like WHO to support your member states. Can you give us a sense of what we're getting out of that? What are you pushing forward from the Commission?
Okay. We are not only doing thinking, but we are doing activities, as you said. In different areas, and always taking into account that the final responsibility is for the member states, how they want to organize their health workforce. Because there is no one solution for everybody, there could be different solutions. But there are some problems that are common, and one of the problems has already been mentioned by Natasha, and is the retention of health professionals. They feel that they are not well remunerated, and remuneration is not just money, it's the possibility of having a career, the possibility if they decide to go to the end of the world, to the medical deserts or underserved areas because they are far away, because they are in rural areas and etc., that they are able to come back or to have a different career. But we have also a problem with education and who enters in the medical schools, and a feeling that we are not doing well in choosing those persons, because the rate of abandon of the medical profession is very high, and especially for the nurses. So, for example, one of the activities that is the more recent is contribution agreement with WHO for the nurses that we have just launched, that is to attract more students to the nursing profession, and also to retain the existing nurses. There are also activities on underserved areas, medical desert. We have 5 projects at this moment from the EU for Health. We have the Joint Action Heroes on health workforce planning that has been running for a while, and that is the continuation of a previous one to improve the databases, because one of the issues also is that we don't know how many health professionals we have, because we are counting in different ways in different countries, and we are counting sometimes the health professionals that are registered in the different colleges of health professionals, but not what they are doing and where they are doing that. Also to build the capacities of the member states for planning. We have a training initiative on digital skills for the health professionals. We have a skill partnership that focus on a skill strategy for health workers, and we have we are always revisiting the directive of qualification, professional qualifications of several professions, including some of the medical one, but this is not under our competence. But we have the impression, that we are waiting for the priorities of the next Commission, but the health workforce could be among the one of the priorities. And also, we have next week in Gastein, the European Health Forum for Gastein, we have a specific workshop dedicated to health professionals that will be in some way a continuation of the summer school that we had in Venice this year with you, with the WHO, but that will be a dedicated one to think about that. Thank you.
Indeed, lots of things going on, lots of value added. Pedro.
Sí, muchas gracias. Isabel, voy a cambiar ahora.
Thank you, Isabel. I'm going to switch to Spanish now. So I will meet you in Castellín, definitely, next week. And going back picking up on some of the comments, we try to think on reforms as a game. We need more people, we need more money on the table, but it is just a lot more complex than that. I have a question about that and the future expected reforms in Spain. Javier Padilla, what are the next steps going forward in Spain?
As all my colleagues are speaking in English, I think I'm going to sum up to them. So, in first place, all my colleagues have been speaking about primary care as one of the main explanations of our capability to deliver a good quality service, and also to decrease the inequalities in our health system. And I think that one of the challenges that we have for the future is having the possibility of updating the primary healthcare values to 21st century. I think that Enrique was talking about the need of having a non-fragmented system. I think the primary healthcare is the pre-existing condition for a non-fragmented system. So, in my opinion, we have to update the accessibility, longitudinality, the coordination of different assistential levels, and the community perspective to 21st century. This is one of the things that we are trying to tackle on the new action plan on primary healthcare, that I think that we will be able to present that, but there are 4 things that I think that they are especially interesting. The first one is about how to tackle from public policies the longitudinal care. Okay, so this thing of having the same professionals for many, many years, that we know that it decreases the number of visits to emergency care and the mortality. So this is one. The second one would be about accessibility. That is very, very important in our country. The third one about the skill mix, and I will go with that now. And the fourth one is about how to place primary care in the center of the different processes. We really have the best way of integrating care. It's called primary care, and it has the capability of integrating care not only among different healthcare structures, but only during the time. So it's like a 4D, like a 4-dimension integration with the time. So I think it's really important. About human resources or health workforce. Natasha was saying demography is what it is, and politicians are what we are also. So many times it's very difficult to find people trying to make policies in the long term. So we really have the mandate to look at the present, but take some decisions looking to the future. For that is that we are, I think, taking some decisions regarding the medical graduates and also on the specialization on very different categories in order to look at 15 years perspective. But also we have already created the National Register for healthcare professionals, that I think that we have already registered 3/4 parts, the 75% more or less of the different healthcare professionals, in order to be able to have the tools to make the prospections and to take the different decisions. But I think that the challenge we are facing, the most important challenge we are facing during our mandate, is having a real impact on the skill mix, being able to change what is being done by whom. And it's very important, especially in primary care. Being able to update the different competence framework is, I think, our most important challenge, and we are going to work with WHO Euro. One of the things that we are going to do is we are going to celebrate here in the Ministry a national conference on health workforce, and after that, as a result, we will be trying to apply the framework that was a result of the Astana meeting in our concrete reality. And we will do that together with the autonomous regions and together with the WHO here.
Thanks very much, Javier. We need to move on because we want to have...
Gracias. También nos gustaría contar con los puntos de vista de las personas que nos están siguiendo online y que están aquí también presencialmente. Han hablado del acceso a la atención, de la igualdad, la importancia de contar con un mix de distintas competencias para garantizar la eficacia. Este podría ser uno de los temas, lo habéis destacado varios de vosotros. Quique, si le parece, vamos a hablar ahora del acceso, de la igualdad. Tenemos un 28% de gasto en España que tiene que ver con pues seguros que la gente acoge o suscribe voluntariamente, estos gastos adicionales, y a pesar de estos esfuerzos, el estudio que hemos visto de nuestros colegas en Barcelona cuenta que tenemos un acceso bastante robusto. ¿Qué podemos aprender de todo esto? ¿Es algo sostenible que se pueda garantizar en el tiempo o es un tema preocupante? en cuanto a mantener este acceso de alto nivel. Vamos a ver si se puede mantener esta estructura, no solo en la atención primaria, sino también en la educación, en el aspecto de asistencia social. Pues vamos a necesitar un aumento de los ingresos para poder garantizar que se siguen prestando estos servicios. Hubo un estudio a finales de la década pasada que hablaba de un aumento del 15% en especies por parte de la contribución de los hogares menos favorecidos. O sea que el diseño del sistema al final afecta mucho. No estamos hablando únicamente de atención sanitaria, sino también de los servicios sociales y ver cómo financiamos estos servicios. Eso por un lado. Por otro lado, el acceso. Vamos a ver, el motivo ahora mismo es que la atención primaria está ahí, es algo que uno encuentra fácilmente. El centro de salud está a la vuelta de la esquina y además no se cobra, ¿vale? Con lo cual, si esa opción desaparece, si aumentamos las listas de espera, esto es algo que ya ha mencionado la señora ministra, lo que estamos haciendo es alterar el valor de este sistema sanitario y lo que estamos haciendo es aumentar luego las necesidades que habrá en el futuro. Son dos cuestiones que a mí me gustaría recalcar. Y luego está también la consecuencia. ¿Cuál es? Pues que la gente acude a los seguros privados. ¿Qué está haciendo la gente? Comprar tiempo. No están optando por un servicio mejor. No es un servicio mejor que el que ofrece la sanidad pública. Lo que están haciendo es recortar el tiempo de espera para acceder a esos servicios. ¿Y quién accede a esos servicios? Bueno, pues aquellos que tienen rentas más altas. Gracias, Enrique. Pues si les parece, me gustaría volver a Natasha. Hemos hablado de que España cuenta con uno de los mayores sistemas de pagos adicionales, estos out of pocket, pero España también es uno de los países con mayor protección financiera en el caso del sistema de salud. Así que me gustaría preguntarle a Natasha, porque sabiendo esto y sabiendo que España ha mejorado esto con los topes en los gastos, con los umbrales y con las exenciones que se han creado para algunos de los gastos, a mí me gustaría que desde una perspectiva internacional me dijese qué podemos aprender de otros estados en cuanto a la protección financiera o a estos out-of-pocket payments. Bueno, gracias, Pedro. Pues tal y como ha dicho antes Enrique, y lo ha dicho muy bien, cuando examinamos la cuestión de la protección financiera hay que verlo desde dos ópticas. Por un lado está la base jurídica, es decir, los derechos, todo el mundo queda cubierto, esto ya lo ha dicho también la señora ministra. Y luego está la cuestión del diseño, las excepciones, la utilización mínima de los copagos, porque al final estamos hablando de una mezcla. Están los copagos que entran dentro de la parte pública y luego la parte privada aparte. Entonces hay que tener siempre en cuenta que los copagos tienen que ser algo que esté controlado y esto ha ayudado mucho en el pasado. La segunda óptica, desde que lo tenemos que ver, es hasta qué punto es efectivo este sistema en la prestación de servicios. Y de esto no estamos hablando. Por eso Enrique lo ha sacado a colación y a mí me ha parecido fenomenal. Hay que ver cuál es la distribución de los servicios, porque al final tenemos que ver cuáles son los servicios que están llegando a los grupos más vulnerables. Y entonces cuando falla el sistema ahí, puede contar uno con los mejores derechos del mundo, pero es que al final verá que estos gastos que los ciudadanos hacen de manera voluntaria, pagándolo de su propio bolsillo, van a aumentar. Y lo hemos visto en otros países. Una vez que se supera un porcentaje específico, antes o después, ya no se puede controlar. Ni siquiera el gasto catastrófico, el empobrecimiento del sistema y del gasto sanitario, porque al final habrá muchas personas que tengan que acceder a estos servicios básicos y ya no va a ser un tema de elección, va a ser un tema que tenga que ver con la necesidad. O sea que esto tenemos que seguirlo muy de cerca. Desde el punto de vista de qué se puede aprender de otros países, a ver, algunas cosas. En España, por ejemplo, no se presta suficiente atención a las excepciones para los niños. Por ejemplo, vemos que se está deteriorando la salud de los niños en toda la región. Estamos hablando de renovar la estrategia para niños y adolescentes durante los próximos 12 meses y queremos trabajar codo con España para meternos a fondo, sobre todo en el caso de los niños y de las familias que tienen niños pequeños a cargo. Pero tenemos que tener bien presente también el tema de las listas de espera. ¿Quién se está quedando fuera? ¿Quién no accede a estos servicios? España lo ha hecho muy bien hasta el momento y sigue haciéndolo muy bien en comparación con otros países. Otros países tienen mucho que aprender de España, pero claro, también uno tiene que compararse con otros países y también con lo que ha hecho uno en el pasado. Y eso es lo que tenemos que tener bien presente, sobre todo desde el punto de vista de la prestación de servicios. Y con eso vuelvo a lo que hemos planteado antes del personal sanitario. Gracias. Gracias. Es una pena que no tengamos más tiempo para abordar estas cuestiones. Ewout, una de las preocupaciones era el tema de los seguros sanitarios. Ahora no voy a entrar en el tema de la financiación pública o privada, pero a mí sí que me gustaría que hablases de cómo establecer normas iguales para todos, una regulación, garantizar que haya aportación público-privada y sacar el máximo rendimiento de las inversiones. A ver, creo que este es un ámbito que nos preocupa, porque además ya lo hemos planteado y con razón en varias ocasiones. El tema es que es un porcentaje pequeño, pero está aumentando y se corre el riesgo de generar un sistema como a dos velocidades. Y esto no es algo nuevo, lo vemos en otros países también. Por ejemplo, hay países en Europa que cuentan con sistemas de aportación voluntaria mayores, Francia, Eslovenia, Países Bajos, Bélgica. ¿Y cómo han respondido a esto? Pues con dos enfoques, una mayor regulación, claro, para hacer que sigan siendo servicios asequibles, para que no se diferencien en función de que haya unos servicios premium y otros no, porque es que si no al final solo se va a atraer a la renta más alta, claro. Eso hay que evitarlo y también hay que hacer que todo el mundo acepte suscribir estos paquetes voluntarios y, en cierta manera, se pueden reducir algunos efectos que va a haber inevitablemente, como la desigualdad en el sistema. O sea que está el tema de la regulación, claro, tiene que haber un seguimiento muy estrecho para ver que realmente no estamos generando efectos adversos de cara al futuro.
De nuevo a Secretaria de Estado.
In order to conclude, I would like to ask the Secretary of State about these challenges that we're talking about. For instance, the possibility of having a public system with private insurance schemes, or maybe increasing the services, reducing the levels of co-payment. For instance, because if we have a health system for poor people, then it's a poor health system.
I think that there is something like kind of a structural between the countries with the highest financial protection, and I think from the top 6, 5 were national health systems. So I think that we should keep really tight to this fact, when we are thinking about what reforms we should do. Most of the out-of-pocket payment here in Spain comes from the non-covered services, so especially things related to oral health and also the everything related to visual health and some others. Regarding oral health, in the last years, there has been an increase in our services provided in the health system for children. And now we are in a situation where we should monitor the real provision that we are having with this oral health implementation. And we are trying to face for the next year and in the starting of the incorporation of elder population, not with a preventive perspective, but also with a curative perspective. And also, one of the biggest challenges we have for the next budgetary year is the incorporation of the glasses, the visual health elements, glasses and other lenses, especially for children. So we are trying to focus on elder population with oral health and on children with visual health, that we think that there are two of the topics related to the out-of-pocket payments. And we are now facing another special unmet needs place to focus is everything related to mental health. And this, I think, that cannot be addressed in the same situation with oral health or visual health. You know, we are talking about a growing amount of individual psychological suffering, but the causes are not something that we can heal just providing consultation. So there are the social causes, and we are trying to focus with a public health perspective on these mental health issues. And I think that we are going to approve the action plan on mental health 2025-2027, and there, I think, from a community perspective, I think we will be able to tackle some of these things.
That's very helpful, Javier, because now we are moving to the third block where mental health integrated care, as our colleague Enrique Bernal has told us, are important areas to maintain these levels of efficiency. For those live and online, we are running slightly late, Pedro, I believe. So we'll be finishing around 10 minutes over, and then in the room, we'd like to have more debate, if at all possible, if you agree. So in this last block, we seem to have good efficiencies and value for money. You gave us this very nice, very useful figure where you put avoidable mortality together with PPPS's healthcare expenditure per capita, showing quite a lot of value for money. And then you mentioned 2 or 3 areas where you're worried about that will be important. Well, where you put your money? If you, Javier, Pedro, our colleagues, the minister, do not have, they have to put political emphasis in the next, and priorities in the next measures to maintain and strengthen this efficiency. Where will you put your resources, Kike?
Okay. So one would be proper skills and a good skill mix. Already said, and maybe there will be some extra comment now.
But there are obstacles, right? I mean,
yeah.
I think it was Javier was telling me, or Pedro, that you were trying to make some changes, and you found some resistance of the professions on a skill mix. How do we deal with those?
Well, but we do also have some good examples in Spain.
Indeed.
Let's talk about the Basque Country.
Indeed.
And let's see how they develop with the limitations, etc., and the challenges they're still facing. But when you look at those integrated areas, or the Navarre one, in Navarre they do have a very nice work done on multimorbid patients, the most complex patients that primary care and hospital care should take care of. So we do have very good examples to take some message from, and one big one is about skill mix. And the role of nursing. The role of nursing is prominent in those schemas. So taking a look at nursing is one of my best ones. And the other one could be, because of this restriction of time, about re-engineering. It's again about organization. When Javier was talking about longitudinality or continuity, I mean, we have, say, the basis for that, but we are not using that. And then we've done very good, we have 2 very good examples in the country. One is what we call in Spanish code stroke and code myocardial infarction, code heart attack. And how the system got reorganized to reduce the time to treatment, because it's key. And this has been with emergency care, primary care, nursing, doctors. Is about the emergency care in hospital, is about hospital care, is about rehab. Just because it's around a condition. So let's learn from that as well. So re-engineering processes, getting continuity real. We have examples getting continuity of care in examples, skill mix as the key, nursing as the key in Basque Country and Navarre.
Beautiful and very useful lessons and challenges for others.
Isabel, me dirijo a ti ahora porque...
Isabel, I'll go back to you now. Because I know that as part of the efficiency and in adding value to the health system, something important are the health technologies. And I understand that this is very important for you. And as a country, it's important for us too. So we'd like to know what your point of view is in terms of the Commission and towards Spain that may be important in the next few years.
We got a regulation on health technology assessment, and I know that last week you had a huge event here at the Ministry with a lot of success. Here, what Spain could provide is more than 30 years of experience on doing health technology assessment. And health technology assessment that doesn't refer only to pharmaceuticals, but also medical devices, but also a lot of techniques and procedures of if it's more efficient to do a prevention program or a treatment or for some diseases or for tobacco smoking, stopping, or whatever. So it has to be large. It's something that is larger, because we are doing many things with very low value, and we continue to do that, and we don't know why we continue to do that. And this is something that is in all the European Union. And there are, in the group of health system performance assessment that the Commission established with the Member State, there will be a work, a study that we are going to do on that area, probably with the observatory, as usually. But that is really very important. For the health technology assessment, there are many things that we need to develop, including who is going to take care of that in the European Union. You know, the debate about agencies or not agencies, and etc. But this is very important that we agreed on doing that, and that we are now really doing that. And where you, I insist, you could teach a lot to other countries. I would like also talk about, I mean, not only the health system performance assessment group, that is quite important, but there are many other instruments that could support the member states, European Union instruments. I'm referring when the member state could look for support to specific areas, and one of them is the technical support instrument, and that we have been doing. I look at Josep because the observatory has also been involved. And 3 countries have been the Guinea pigs for that. That is Austria, Belgium, and Slovenia, in very specific areas. One of them was mental health, the other one was primary health care. So different areas where they had specific problems, and they requested the support of the institution to solve that. So there are many different areas where individual member states request, but that Belgium was not acting on itself. They were working with Slovenia and with Austria. I mean, why those countries? Because they were the ones that proposed, that offered to do that wanted to do that, and because they had very specific and very urgent problem. In the case that Spain, for example, decided to do that and request the support, we are now discussing how we are going to do in the future. Thank you.
Thank you. Thank you very much, Isabel. I think that,
sorry.
No, I think that even though we've been talking about health technology assessment from 20 years, 30 years, whatever, but there's a need to still push forward for that, and I think you will find that Spain will do that in the next years.
Absolutely. Ewout, difficult task for you now. In 2 minutes, as they say in concourse, you know, can you sort of do a couple of reflections on the integrated care, the mental health? It's been said several times as one of the challenges across the region. I know you personally have been leading a lot of research and analysis in this field. Can you leave us with a couple of thoughts on that, please?
Yes, so I totally agree with you, Enrique, that you have great models already here that are proactive, embedded in primary care, use risk stratification. They are the envy of many other countries. The only issue is how do you scale up, how do you implement, how do you roll out further? And even for that, you have the technological capacity within your borders, like for example, Groningen and now Biosystemak, who is also really in that field, focused on multimorbidity, exactly what you should be doing. And yes, we're doing lots of work, and what we learned from that is some of the issues that you said are important, like multidisciplinarity, but also leadership is really important. Financing methods that also have, a built-in mechanism that if it works, you'll be funded, So the best programs end because money runs out. That shouldn't happen. But if you ask me where should we put the money in terms of also mental health and integration, I'm thinking of early childhood intervention. We are seeing, of course, huge numbers of people with mental conditions facing our country, and we should catch that at the source. Have policy that really address the risk factors that lead to mental health issues later. So you can think of even low birth weight or domestic violence. Poverty is an incredibly important issue. And the only way you deal with that is indeed with an integrated approach that doesn't only connect the health system with the social care system, but also the educational system, as you also mentioned before, Enrique. Very important because you can catch many things in school. It's often the case that the people facing the highest barriers, the children who are most vulnerable, have the highest barriers to access care. It can be financial, it could be coverage issues, it may be a language issue. There are several reasons why they particularly cannot access care. So there need to be developed policies that are really tailored at this group of people. And for that you need incredibly good data, and that's something I think in Europe that we see that we can do better, and that we should perhaps also collect data specifically on vulnerability, because often we don't do that. And then in terms of this targeted outreach, you should really think of school-based programs, perhaps navigators who help. Of course, there are all kinds of online tools that can help inform people, school-based programs, but let's remind ourselves here that probably the best intervention you can do is not in the health system. It's really about fighting poverty and giving people housing. Those are huge risk factors that need to be addressed, and therefore I think also those connections need to be made. Thank you.
Javier, para cerrar, tenía 3 temas que te iba a...
To close, Javier, I have 3 matters I wanted to ask you, and I'd like to give you the opportunity to choose what you want to talk about. In terms of the skill mix that we've already mentioned before, integration, health integration with other systems, or low-value intervention. So, Javier, what would you like to talk about? I'll leave it up to you.
First of all, when talking about efficiency, I would like to start by saying that our health system is sustainable not in spite of being universal, but as a consequence of being universal. So when we are talking about efficiency, we should be talking about the pre-existing condition of universal health coverage as a condition of possibility for that. Starting with, about the skill mix, I think that we have been talking about that before, and in fact, I feel like more comfortable talking about skill mix when talking about access and equity and not about efficiency. Because I think that the skill mix and the new design of the competence framework should be seen not only because of efficiency, but as a matter of integral development of our professional workers. So I think for me it fits better in the other place. About integration, we created 1 year ago, 9 months ago, the Mental Health Commissioner. She is that there is a position, especially in order to tackle everything related to mental health with an integrative perspective, relating with education ministry, with ecological transition, and ministry with social rights ministry, and the framework where we are working about mental health is the community framework, and the new mental health plan is going to be published, integrating different actions in many different levels with this perspective. Also, in addition, we are also working in a plan of children welfare school-based interventions, especially for the after-school time, in order to act not only what we were meant to do at the first time, that was child obesity, but also from a more integral perspective of children welfare. And we are also working together with the Social Rights Ministry in something that I think it's like nuclear, that is very important when talking about children's health, and is all the interventions we should do in the early stages of neurological development. This is something that is aiming to prevent further inabilities, and I think this is something also we are trying to work with. And about the low care values, well, I think the health technology assessment issues are also focusing there. Also in the primary care action plan, there is going to be like specific interventions in order to de-medicalize and to act on the low-value interventions. But I would like to tell an hypothesis. I think that one of the things that might be related with the low impact of the high percentage of private expenditure is like there's a part of the private expenditure tightly linked to the low value care. So I think the high value care is like kind of monopolistically provided, not so drastically, but kind of monopolistically provided in the public provision, the public health system. So I think this could be one of the hypotheses of the linkage between the high percentage and the not inequality figures.
Thanks very much. Sorry we're running late. We have some questions from the online. I'll ask you after the questions from online and from the public present here to have one final set of reflections, but very, very quickly. Any reflections from online? Cristina?
Thank you, Josep. I just want to share with you that there has been a lot of interest in the chat, and they've been interested in a range of areas, starting with primary care, access to healthcare, low-value care, even palliative care related with this high life expectancy in Spain, mental health. But in terms of questions that haven't been resolved yet, maybe I would highlight the issue of access to primary care. So what they were saying is whether digital strategies, well, they want to know the national perspective and the international, in the sense that which are the digital strategies that could be implemented to improve this access to primary care, if that implies new categories of professionals as well, etc. So they saw, as we have discussed, the shortages of healthcare professionals, whether digital strategies would make a difference. For the others, low value of care, you resolve it already, and the rest. Thank you.
That's very, very helpful. Thank you very much. Can I get some views from those of you who've been so kind to join us today, and some reflections, please, to wrap that up? Probably the people online may start leaving. For those online, remind you, and those here as well, that after the break we have a second key session, which is alcohol and youth, one of the major challenges for health promotion, health protection, health promotion. So can I have some views from here, please? Short views to what? Please say who you are and your point, but very shortly. Tweet this time.
Yeah. Hello, I'm Alfonso. I'm a recently graduated doctor. I wanted to ask, what aspects do you think health policymakers should pay special attention to that could lead to an increase in health spending in the following years? I'm thinking maybe about the care for elderly patients or dementia patients, which right now falls mostly on households. Thank you.
So maybe that one to you, Javier, post-containment in the next few years. And maybe the digital, perhaps with Natasha would want to mention, and perhaps Isabel. More points, please. Yes, thank you. Short and sharp as well.
Of course, thank you so much. Alison Mawson from Euro HealthNet, and thank you so much for all the contributions. I wanted to come to that point about multi-sectoral cooperation, because I think that's a very interesting one, and it came out at the EU level from the synthesis report, and I know we've heard a couple of examples from Spain. It would be very interesting to know from the efficiency point of view, how does that support the efficiency of the system to bring schools together, or look at these determinants of health? And I had one quick clarification point I wanted to ask Isabel. about the health expenditures in 2021. You said it was 6%. Was that including COVID vaccine expenses? Was that part of that? And maybe that explains, because we always talk about this famous 3% spending on health prevention budgets. Thank you.
Perfect. Maybe Kiki on the determinants, because you made a point on that, and Isabel on the expenditure, perhaps both. Yeah?
Thank you very much. I would like to ask a question. I work in the optical industry, and I would really like to thank the Ministry to put visual health in the forefront, because it's really important. So I would like to know if you have some plans, or when are we expected to know something from your side, where and how it's going to be implemented. Thank you.
So perhaps that one goes as well to Javier.
Catherine Perez, International Association for Hospice and Palliative Care. You had a slide on universal health coverage with the organic euthanasia law, and I was wondering if palliative care is part of universal health coverage in Spain.
That's an interesting one, perhaps, Kiki, because I noticed you had that in there as breath, I think. Maybe you want to take that one, or perhaps Javier wants to add on that. I can have another couple of points, although we're running late, but this is very exciting. I wish we had managed to open earlier this debate. Nope. Yeah, last one. Oh, last one will be you then.
Thank you. Hello. Isaac Bencomo from the London School of Economics. Just Javier's last point on the distinction between high-value care and low-value care, and how that you can perhaps segment the out-of-pocket payments, and you can potentially argue that although it is quite large in comparisons to the EU average, it is providing a slightly lower aspect of the lower value care versus the public sector. Thank you.
Maybe that's something for Kiki and Ewout. I'm making a point to divide, because if you all answer these questions, we'll never finish, yeah? So please be taking your areas.
Thank you very much for all these talks. I'm Mara Parellada from the Spanish Brain Council. I think I heard that you said a third of the avoidable deaths is because of risk factors, and the second one that you mentioned was alcohol and illegal drug abuse in youth. I was wondering what's the approach that you're going to make, and how does this combine with the different policies of cannabis legalization?
Excellent. I think especially Kiki mentioned that, and of course Javier. Friends, so now you have a challenge in this. I'll start with Kiki, and I'll go up to the right in that order of your city.
I don't know if I've taken everything correctly, so just correct me, people. About whether a multi-sectoral approach is more efficient, I got the point correctly? We don't know. We assume that if you end up having healthier people when they're young, they are going to use the services stronger. But we don't have really good examples, at least, I don't know, that can be, basically because healthy lifestyles are very complicated compared with across countries, environmental issues. We assume that this is a good hypothesis to follow, and I, as public health specialist, I would assume it myself as one, but I cannot tell you, I cannot say, well, more of this would reduce this, or the other way around. I would go on that line, though. Absolutely, absolutely, but I cannot say, well, the evidence tell me that yes, doing this. The examples we have with tobacco in Spain, we don't have formal evaluations about where we have reduced the number of hospitalizations, use of primary care, or COPD. We don't formal at scale. We have small results, promising, but I cannot say, honestly. About palliative care. Palliative care is one of the benefits in the basket of benefits, so it's included. It's not that we are resorting to euthanasia, because no. So palliative care is one of the benefits. We can argue, though, that it's well resourced or not, as any other benefit, so to say, or is not well organized, or is being well organized here or there and not here, but it's not nothing to do with, it's not provided because it's one of the benefits. for years. I mean, I'm talking decades.
And also in terms of palliative care, there's now new research, old research as well, as you know very well, that it's not only about cost effective in terms of the quality of the patient experience, but also in life expectancy. Actually, patients in palliative care in hospices end up living longer and better quality than being in acute care, which is quite interesting and quite counterintuitive sometimes in the way we think about that. Isabel, there were issues about numbers, there were issues about digital as well, that you may want to address, or any others.
Numbers, I will say that that will have to go to the authors of the report, that they know better. But yes, in principle, vaccines are preventive measures, and they are under that expenditure. Sorry, about digital. Now we have recently approved, we all, I mean, the Council, the European Health Data Space Strategy, the regulation, and that we hope that will support, well, to have more data, but also to be able to work more on the digital areas, especially in the healthcare sectors, with all the different projects that we initiated many years ago, some years ago. One of the key issues is that for that we need infrastructure, and second, that we need health professionals that are well equipped and that understand well the issues. So it's a matter of skills, and I mentioned before as one of the projects that we are doing with the reinforcement of the health work care. There has been support from the EU for health, but also from Connect Europe, and also for all the recovery funds that have been put in place by the Commission after the COVID-19 pandemic. So I think that there is hope for that. How we are going to regulate the access to primary health care and digital, this is for the member states, as I said, but we are working all together on that.
Excellent. Javier, I'll leave you for the end because you helped me to conclude at the very, very end. Natasha.
So I will tackle digital strategies, primary care. Of course, absolutely, yes, there is a role. There is a role when it comes to telemedicine, particularly in rural areas. There is a role when it comes to remote monitoring of patients inside their homes. There is a role when it comes to assistive technologies. We can do much more when it comes to proactive population health management, looking at the data, knowing where the hotspots are, knowing who is being left behind. But at the end of the day, digital alone can only take us so far. And we have to be careful not to completely lose the humanity from our health systems. So in the ideal world, the digital does what it can do well to allow us to really use our very precious human healthcare resource to do what AI and digital can't. And we need to get to that point. But of course, then you need to link to the hospitals. We can't just imagine that PHC exists in isolation. Digitalization means that there is now also the seamless interface between hospitals and primary healthcare, and we need to think through this very, very carefully as we approach the European Health Data Space. Just one small comment, because the gentleman mentioned dementia, elderly persons. Just to say, this links also to the way in which we really want to look towards the future. We have to do two things. We have to quickly reorient our care systems to deal with the older people now and the incipient older people, no, the baby boomers, who are coming in larger numbers into our health system. And we are not really ready for that yet. Our health systems are still not sufficiently attuned to a population that in a large part is made up of older persons with a different kind of need. With the other hand, then we need to really work on making sure that our future populations are fitter and healthier. And we believe that by investing in early childhood health, in early childhood interventions, we can hopefully have a fitter and healthier population that, amongst others, will also be better able to survive health threats. We know this from the COVID pandemic too, that populations that were sicker were less able to cope even in the face of adverse events. Thank you very much for allowing me to be part of this panel.
Thank you, Natasha. Ewout?
What I would like to comment on is that we've been talking a lot about the workforce issue and about training, recruiting, retaining workforce. And, you know, that will help, but it's not a solution, I think, going forward alone. There are other sectors, just think of the educational sector or any skilled workers. There's incredible pressure for workers. So I liked actually what you said, Enrique, at some point when you were talking about effectiveness, the need for perhaps disruptive systems. That sounds very dramatic. I would rather say new models of care. I think that we should really invest there and try to see, you know, how can we do more with less people, or even do better with less people. And then, oh, that's you, Giselle. And then, you know, or is it me? No, it must be you. Or perhaps do, you know, do more with hospitals at home, having new models also for long-term care, rehabilitation. I think those are areas that we really now need to make progress on, and I wanted to end on that note. Thank you.
Thank you. Javier Padilla, Secretary of State, if you want to conclude us with some final comments, please.
Thank you very much. To comment some of the questions. Well, some of them have already been answered. I think that we have done very great efforts on everything related to digital strategy, but especially at the primary care level. I think that we should outline that. We were talking, I think, online. There was a question about the new categories of the new professional categories in primary care. This is one of the interventions we want to put on our new action plan on primary care. It's trying to rethink the primary care teams in order to add some new categories. I'm talking about, for instance, nutritionists or podologists or some other categories. Well, third, about health expenditure, the elderly, I think that the main drive of the increase of the health expenditure is mainly the intensive incorporation of new technologies, and I think with the health technology assessment initiatives, I think we will go some steps ahead, but also next year we are going to face the approval of regulation of the pricing and financing of new drugs and health products here in Spain. About the visual health implementation, we are working together with the optometrist college and the ophthalmologist society in order to go towards I think an agreement on how to implement this concrete policy, specifically focusing in the beginning on children. About palliative care, the right is universal, the provision is unequal. I think that we could say that in general, provision of palliative care in general should be like a competency for primary health care, but there are the support teams that could be placed well in primary care or in hospitals. We have the strategy of palliative care, and the ongoing strategy should focus on the inequalities in the palliative care provision. And the last one, I think that it was about some mention to cannabis, like related to the substance abuse is one of the causes of premature mortality. This ministry is working on the therapeutic use of cannabis derivatives. This is nothing related to the cannabis regulation. I have my personal opinion from a public health perspective on the capability of regulatory policies in order to decrease the consumption, but this is not a matter of the current ministry. So we are focusing on the regulation, on the therapeutical, the medicinal use, and I think we are going to be able to look at the first draft in the next weeks. Thank you.
Thank you very much. Friends, those online, still left online, those here, my personal apologies because I've been a lousy moderator, but there was so much we needed to thresh out. I am aware that there's been a lot we have covered, but our main objective was for you to look at this material, read this stuff, use this stuff, look at the wealth of comparative analysis we have there to support policy. So if you could bring your hands together to thank these wonderful participants and to thank yourselves for being here. Thank you.